Welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. I'm Dr. Louise Kugler, a specialist GP, and I'm delighted to introduce Dr. Nicky Keay to discuss primary ovarian insufficiency and early menopause. Nicky is an honorary clinical lecturer in the Division of Medicine at the University College London, where she lectures and researches in areas of exercise endocrinology, with publications in this field. Nicky's clinical endocrine work is mainly focused on active women, exercisers, dancers, and athletes, with a focus on relative energy deficiency in sport, or RED-S, and those navigating the perimenopause and menopause. Nicky is the author of Health, Hormones, and Human Potential, a guide to understanding your hormones to optimize your health and performance. Nicky authored the British Association of Sports and Exercise Medicine online resource and is the medical advisor to the Scottish Ballet. Hello, Nicky, and welcome to the podcast.
Thanks, Louise. Yeah, delighted to be here speaking to you live, actually, in New Zealand itself. Wow.
So we are talking about primary ovarian insufficiency and early menopause. So I wonder if we can just start with some definitions, please.
Sure. Primary ovarian insufficiency means reduced ovarian function occurring in a woman before the age of 40. And this contrasts to early menopause, where reduced ovarian function, but in between the ages of 40 and 45 years. I think the reason for this is the average age of so-called natural menopause is anything from 45 to 55, with the average being 51. So you can see that anything earlier than 45 suggests that there's something else. It is early, but it's in those sort of time brackets. So just to repeat that, if it's 40 to 45, then that's early menopause. But if it's before 40, then we call it primary ovarian insufficiency.
Fantastic. Let's think about risk factors or contributing factors to primary ovarian insufficiency and early menopause. Are there any?
Yes, and it's sort of like the usual surgical sieve that we call it, certainly in the UK, that, there could be a genetic element to this. So we know that there are specific chromosomes abnormalities associated with POI, primary ovarian insufficiency, and especially in those situations of primary amenorrhea where the periods don't even get going. So we're thinking about Turner syndrome or something like this. So that's one sort of category. Otherwise, sort of genetic, it could be just like a polygenetic thing, maybe something in the family, but we can't obviously identify a specific gene. It's some contributing genetic factors there. There is also a question mark whether lifestyle factors might affect it in this situation. So if you have a genetic propensity towards POI, and maybe lifestyle factors, maybe you're smoking and not leading the healthiest life you could, maybe that would contribute as well, but that's not so certain. The other group we have, so we've done genetic, and then the other group would be, I would say, medical reasons for POI or indeed early menopause. And those could fall into sort of autoimmune conditions. For example, if you've got Addison's disease, primary adrenal failure, or hypothyroidism, underactive thyroid with the autoimmune link, that could also be associated with autoantibodies, the ovaries themselves. There's also a group of women, iatrogenic causes, so who have had chemotherapy for, any type of malignancy, and that can cause POI. And then there's the surgical group, so women who have had oophorectomy, maybe as part of a hysterectomy, or ovaries removed for other medical reasons, be that malignancy or severe rupture of a cyst or something like this. So they simply don't have the ovaries to be producing hormones. So that's how I look at it: genetic, query contributing lifestyle factors, and then the sort of medical and surgical causes.
It's a great way to break it down. Thank you. So thinking about prevalence of firstly primary ovarian insufficiency, how common is this?
I mean, thankfully, I suppose you could argue not that common. Up to 1% of women are said to experience POI. And there are some women who it might be even earlier, under the age of 30, but this is even a smaller percentage, 0.1%. So, it's 1%, which sounds a low number in percentage terms, but nevertheless, that's still going to be quite a lot of women. And obviously, it's, as we're going to go on and discuss, Louise, that's super significant for them as women, as individuals. So, yeah, it's definitely something that we should be talking about and thinking about.
So, compared to early menopause, what's the incidence there?
So, the incidence there are a little bit more frequent. That's said to be 5%. So, 40 to 45. Again, it's not the ideal a situation because the ovaries aren't just about reproduction. They're about producing these amazing hormones, which are important for all aspects of our health. So it's a slightly higher number, the 5% compared to the 1%. So again, a group of women we need to be on the lookout for to offer appropriate support, etc.
Right. So, Nicky, thinking about typical symptoms that a woman may present to primary care with if they're experiencing primary ovarian insufficiency or early menopause, and then how are those symptoms impacting on their overall health and well-being?
Well, the presentation is similar to menopause or perimenopause, should I say. So the first thing the woman might notice is that her menstrual cycles become irregular. And then she might start noticing some typical menopause symptoms. For example, the hot flushes, brain fog, sort of forgetfulness, mood changes. So all the sort of symptoms that you associate with natural menopause, all of those things would apply. Disturbed sleep, for example, maybe genital urinary problems, aches and pains, which aren't caused by injury. So there's the full list that we usually think about that women can experience at menopause. But in the case of POI, because it's sort of like it's not menopause often, it's not a full stop. So the ovaries might have a second wind now and then. So I think this is why a woman with suspected POI, she might not experience severe menopausal symptoms, unless, of course, we're talking about a woman who's had her ovaries removed, and then there's obviously no opportunity at all for the production of these hormones, estradiol and progesterone. But that, I think, is something, another little sort of a little bit of advice that absolutely consider it in a woman presenting with irregular cycles, but don't be fooled that the woman says, "Oh, I'm actually fine," because it might be that it's this intermittent pulse I'm talking about. But obviously do ask, because women sometimes sort of put up with things, don't we? We just soldier on. And if actually she says, "Oh, no, I'm fine," then actually direct questioning in that case. Well, have you noticed that you're becoming hotter than usual? Or have you got disturbed sleep? And then the woman might say, "Well, actually, now you come to mention it, yes." So if they don't volunteer these symptoms, then I would definitely suggest sort of a direct questioning to see if these symptoms are occurring, and of course if this is impacting our quality of life. That's the key thing. If the woman says, "Well, actually, yes, I am getting really forgetful and it's really impacting how I can do my job," or whatever, then obviously that is significant for that individual. So that's the sort of the immediate presentation, but we have to consider that if the ovaries are working part-time or stop working, then this can potentially have long-term health consequences. Just like as with menopause, we all know that the decline in ovarian hormones is associated with, of course, risk of poor bone health, and also cardiovascular health can suffer as a result of this. So certainly there's the immediate things to be considering, quality of life, etc., and symptoms, but also one has to think about the long-term consequences on health, which might not be obvious immediately.
Sometimes we do get fooled because of the intermittent nature, and we may dismiss this, and that may be why often the diagnosis is delayed.
Yeah.
So if we're wondering about primary ovarian insufficiency or early menopause, what investigation should we request and why? And then how quickly should we start investigating?
Well, the definition of secondary amenorrhea is 3 consecutive missed periods. But I was looking into the details exactly of what's recommended in the situation of POI, and the European guidelines say 4 months of amenorrhea, which I suppose you could argue that is 3 missed cycles. So, one missed cycle, maybe one's not getting too concerned, or indeed even 2, if then they resume. But certainly 3 missed cycles is sort of when you start thinking about, well, actually, let's ask some questions about symptoms and let's start considering doing some tests that we're going on to describe, just to make sure, to see what's going on, basically, because all women of reproductive age, from the age of menarche, average age is 12, up until the natural age of menopause, 51, during that time, all things being equal, you would expect a woman to have regular cycles. So obviously, secondary amenorrhea is a red flag. It means there's something going on. It could potentially be just a temporary little pause, and that's fine. But as you say, delaying diagnosis of whatever the underlying cause is, number one, it's not good for the woman's well-being at that moment in time, but also thinking about her long-term health. So I would have a low threshold to just check in and see what's going on.
And then is there an accepted diagnostic criteria for standardizing the diagnosis of POI?
I was just looking over the guidelines from the European Society of Human Reproduction and Embryology, and they say, as we just mentioned, start doing the blood tests, amenorrhea 3-4 months. And they say if the FSH is greater than 25 international units per litre on 2 occasions, 4 weeks apart. So again, taking into account the intermittent nature of this. So 2 lots of FSH, at least 4 weeks apart. And they quote the level of if it's greater than 25. However, the British Menopause Society say if the level is greater than 40. Probably, I would say, because this is a significant thing for the woman, for her and for her health, I would actually go more with the European and say, 25 FSH is high, it's definitely high. And if that's occurring on 2 occasions, then, that's pretty much in the bag, the diagnosis.
Wonderful. So moving on to management now, what are the goals of treatment in POI and early menopause? What do we need to be thinking of?
Well, I suppose you could divide it into 3 things. Well, first of all, that's the woman's well-being right here, right now, today. If she is suffering with symptoms, whatever those might be, then obviously one wants to be improving the quality of life and helping those symptoms. Also, depending on the age of the woman, fertility, especially nowadays, women having children in their 40s isn't unusual. So again, finding out and asking what her desires are regarding fertility. If she says, no, I'm not interested, or she's already had a children, then that's kind of that ticked off. But if she said, well, actually, this is how I found out, by the way, because I was trying to get pregnant and there was a problem, that could be something significant. And then the third thing is the long-term health piece. So it's the current, how's she feeling right now? What's her quality of life? What are her thoughts about fertility or wishes about fertility? And also remembering, this woman, you're going to be supporting her as she gets older and her long-term health. So those are the areas I would be thinking about.
I wonder if we can touch on hormone therapy.
Certainly, as with menopause, the first thing is lifestyle. Right. So, that's easy to, well, I say easy, it's straightforward to tick off. So let's check in on the lifestyle. Is the woman, has she got decent nutrition? Ideally, fresh produce, all the food groups, all that sort of thing. Is she doing regular exercise? And what are her sleep patterns like? Given that the sleep might be disrupted, but at least if she's giving herself a fighting chance and going to bed before midnight, all those sorts of things. And vitamin D is, I know, well, I've just been on the South Island. It's been wonderfully sunny, I must say. So I didn't bother to take my vitamin D down there. But looking at the window today, it looks a little bit like London and no sun. So I might start taking my vitamin D. So I would always start off with the basics. Let's look at the lifestyle. Let's take vitamin D. Certainly in the UK, we advise everybody to take vitamin D at the very least during the winter months, because the main source of vitamin D is the action of sunlight on the skin. And if you're in short supply of sun, then the supplement, you kind of have to take it because you can't get sufficient from diet alone. So I would definitely start off with that. And that makes the woman feel empowered, because she might be feeling really down that, like, why have her ovaries stopped working? It's like, that feeling of frustration. What can you do to control this? Well, at least doing something positive, proactive with your lifestyle, it's actually makes you feel good in the first place. So definitely that's where I'd start with. But yes, absolutely, you're right. And I agree with you, Louise. Then we do have to talk HRT because number one, the symptoms right here and right now, if she's experiencing any, and also for long-term health in terms of bone and cardiovascular health. So starting HRT as soon as possible is a very good idea. And we're talking about systemic HRT. So both estradiol and progesterone, and also potentially local estrogen for genitourinary health, something that obviously the woman might not automatically volunteer. So again, that's an area, just after you've had all the discussion about everything else, then if the woman hasn't volunteered that, asking directly if there are problems, with vaginal dryness or urinary urgency, etc., then certainly local estradiol will definitely help. If the woman hasn't volunteered, that she's getting any problems there, she might be relieved that you've actually asked that, because then you can offer the solution of the local estradiol. So that's an addition to the systemic. You can use both together. In terms of, questions people say, well, if it's a young woman, she might not feel comfortable taking HRT. What about the combined oral contraceptive pill? If the woman really is adamant she does not want to take HRT, then obviously you're not going to deny her the combined contraceptive pill. But we know that this is not so effective as HRT for either bone or cardiovascular health, indeed, because the action of the combined contraceptive pill is to switch off the pituitary in its production of FSH and LH. So even if the ovaries are sort of going part-time, as in POI often, that will actually stop the ovaries themselves even trying. So it is effectively a medically induced ovarian shutdown. So I will just explain that to the woman. It's like, look, ultimately it is your choice, but this is what's on the table. The HRT will replace and replenish the estrogen and progesterone that you're low in, whereas the combined one does provide some synthetic forms of these hormones, but it is not the type of estrogen that is recognized by bone, so therefore it won't be so good for your bone health. And often when I've explained that, well, number one, the woman often looks at me in a very surprised manner, thinking that no one has told her that the combined contraceptive pill actually shuts down your ovaries. So that's number one. And, then she can make that informed choice. It's like, well, now you've explained it like that. Of course, I want to take the HRT because that's going to be best for my health. So that's the little story there about the combined contraceptive pill. In terms of contraception, by the way, because there will be some women who want to have contraception because they have POI, so there might be an intermittent working of the ovaries, but actually they're not looking to get pregnant. So what do we do there? So in that case, one could consider using the Mirena coil, so the slow release progesterone, which is licensed to be used alongside estradiol as part of HRT. So that would be the neat solution there if the woman is not looking to get pregnant and indeed doesn't wish to, but she's got POI, so might have this intermittent functioning of the ovaries. So that's how I would structure my discussion with the woman. And then in terms of review, how often to review, it's advised by the European Society annual review. At the very least, obviously, if you're titrating the HRT according to symptoms, etc., it might even need to be more frequently than that in terms of just a brief follow-up. But otherwise, annual review to see how she's going, what's going on, is what is advised.
Thanks, Nicky. I wonder if I can pick up on bone health. And obviously, we're using HRT as true hormone replacement therapy. But what sort of doses do we need to be bone protective or bone building? And how frequently should we be doing our DEXA scanning? Should that be more frequent in this population group?
I think, Louise, it depends on the cause of the POI. Because if it is the idiopathic POI where there might be intermittent functioning of the ovaries, then a decent dose of HRT, not sort of mini doses, but it's this general rule of thumb, HRT titrate to symptoms. But on the other hand, if a woman has a surgical reason for POI, so the ovaries have been whisked out, then there's not even any possibility the ovaries they're not there, so you won't get even a teeny little bit of estradiol or progesterone, or indeed testosterone. So in that case, the general advice is that probably this woman will need, if she hasn't got any ovaries, just not there, then she probably will need a higher dose of HRT. And like you, I was searching around to find the exact dosage and everything, but we can't find it. So it's just the general advice of probably you do the usual thing, or what I usually do, or what we usually do in the UK. You start with a low dose and you gradually titrate upwards in terms of the estrogen dose generally, rather than the progesterone is just sort of more or less stable unless you get to really high doses of estrogen. So you try to titrate the estrogen dose up gradually, but probably with surgical POI, then actually you would be thinking it's going to be a little bit higher than a woman who still has her ovaries in situ, albeit they're not working so much. And you're right that the main thing about not having ovarian hormones is the effect on bone health. So that thing about the DEXA, probably it's a good idea to do a baseline DEXA when the woman is first diagnosed, so you get a feel. And again, that will also direct your management. If the DEXA is looking okay, you're still going to have a low threshold for working your way up through the estradiol dose. But if the DEXA isn't so good as a starting point, then you're going to have an even lower threshold for getting the dose up. I mean, I use a lot of gel estradiol because it does offer the flexibility of the dose as opposed to a patch. And certainly there are advantages of transdermal route of taking estrogen over the oral tablet form, because any tablet form, a sex steroid, will be metabolized by the liver and is not so helpful in terms of cardiovascular health. So personally, I always go for estradiol and the gel over the patch because it is more finely titratable. In terms of estradiol pumps, one pump is the lowest dose you can get, obviously one pump. But, in these women, especially with surgical POI, you might be thinking more like even 3 pumps or something, which would be on the higher side for a menopausal woman. But on the other hand, you would probably do 1 pump, maybe 2 pumps for a woman with POI, you see, because maybe she has some ovarian activity. So I'm afraid I haven't got a direct answer for you in terms of dose, but certainly having a lower threshold for the surgical POIs in terms of higher dose of estrogen would be advisable. And also it's said that if you've had oophorectomy, then again, there would be a lower threshold, or at least it's certainly worth a discussion with the woman about testosterone, because, she doesn't have the possibility at all of producing any because the ovaries are not there. So it's one of those things to bear in mind and discuss with the woman.
Wonderful. Thank you for clarifying that. And sadly, we do have the gel here, but it's not on our fund. That's something we need to work on together. So, and we have an intermittent supply of patches. So, yeah, we're not as well as we could for our women in New Zealand currently.
Oh dear. Well, I can say the gel is very convenient and flexible, and there are lots of different types of gel. I mean, there's the pump form, but actually the one in little sachets is even better, because I can tell you, traveling around, you don't want to really be carting a whole pump through, a liquid security. It's just like a little bit awkward. I mean, anyway, it reduces your allowance of other stuff. So having a handful of the little gel sachets is really great for traveling. So yeah, I think you need you need some gel in New Zealand, definitely.
Absolutely. I wonder if we can circle back to fertility and reduce fertility, which is obviously for some women a devastating effect, for others not so much. So once a woman has a diagnosis of POI or early menopause, how likely is it they'll fall pregnant naturally? And do we need to consider contraception if they're not wanting to get pregnant?
Well, obviously, if your ovaries are working intermittently, then your chances of getting pregnant, even if you've got a sort of a later POI, if I can put it like that, if you're like 39, you're nearly coming into the bracket where we would think about, conception is a little bit harder over 40. So, yeah, of course, it's going to be much lower, the possibility of getting pregnant and reduce fertility. But it's not totally off the cards because, like we said, it's this intermittent thing. So if the woman wants to get pregnant, then yes, you have to be clear that it's going to be tricky. It's going to be hard and it's going to be a challenge. And I will leave it to the fertility experts to, about ovulation induction and egg salvage, etc. But there is the possibility of oocyte donation as well for those that want to become pregnant. On the other hand, as you say, for those that don't want to become pregnant, then yeah, sure, you do have to advise about contraception, and HRT is not a contraception. So that's where that combination of the Mirena coil and some estrogen would be ideal, because then you're covering off the HRT and you're covering off contraception with the Mirena coil, which is licensed to be used, you see, as part of HRT. So that would be my suggestion for those women.
And as far as support systems and resources for our women with POI, do you have any that you recommend?
It is, of course, going to be a big challenge for a woman, whether she wants to get pregnant or not. It's just like you're not going to reach menopause as when you expected to, and it's come earlier. And so reaching menopause anyway is a significant milestone in a woman's life, part of her female hormone odyssey, as I say. That's a significant time, menopause, whenever it comes. And so especially if it's a bit earlier, then of course, there's going to be emotional aspects, psychological aspects of this. So of course, we want to do everything we can to support these women and make them realize that they can get the most out of their life with help and support. And in the UK, for example, we have the DAISY network, which is specifically for women with POI. That's for the women themselves to get together. And then in the UK, actually, things like the British Menopause Society, we also include that. At UCL, very exciting, we are developing an information, educational support network for women experiencing menopause, and that will include women of any age experiencing menopause, so including the younger women as well. So there are things that are happening, thankfully, for these women to support them in what is absolutely a challenging time.
Wonderful. So as we conclude this episode, Nicky, thank you for sharing your valuable insight. I wonder if you could give us our top take-home messages for our listeners, please.
Yeah, well, bear in mind that, POI and indeed early menopause, it's relatively uncommon, but that doesn't mean we shouldn't consider it when a woman is presenting to you with irregular cycles or lack of, amenorrhea and symptoms. So definitely don't rule it out and consider it. And if necessary, do the appropriate investigations. And then if the diagnosis is confirmed, supportive approach is obviously key, and finding out what the woman wants, whether she's seeking pregnancy or not. And also, so your treatment is directed and management and support is directed at what she wants right now at that time. What are her symptoms? What does she want to achieve? Does she want pregnancy or not? But also thinking about her long-term health, and the HRT is definitely the top choice and preferable over the combined oral contraceptive pill. And for a minimum, the HRT up until the natural age of menopause of 51. But often women feel better taking HRT. And of course, there's no reason why she cannot continue that after the age of 51. But at the very minimum, it's advised up to that age. So those are my key take-home messages, which I hope are helpful.
Thank you so much, Nicky. We hope this episode has provided some clarity and understanding on this important aspect of women's health. And we will be welcoming Nicky back to discuss secondary amenorrhea in the future. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll also find a list of resources used in this podcast on our website, goodfellowunit.org. Thank you for listening.